Hi, welcome to AETCM. Today we're going to discuss a case about a 55-year-old male who was brought to a ER with complaints of generalized weakness, generalized tiredness with multiple episodes of vomiting. Shall we begin?
Yes.
Sir, in initial assessment, the patient was drowsy but arousable. Coming to airway, airway was patent, no secretions were noted. On coming to breathing, air entry was bilaterally equal with normal vesicular blood sounds and respiratory rate of 18 per minute and saturation of 96% in room air. And circulation, but BP was 150 over 80 with pulse rate of 88 per minute and all peripheral pulses were palpable. And in disability score, GCS was E3, V2, M5 and with pupil 1.5 mm bilaterally equally reactive.
The
And
GCC is only 10.
yes, sir. Coming to exposure, temperature was 98 degree Fahrenheit with GRBs of 130 milligram per deciliter, and patient was covered to prevent hypothermia. Adjuncts to primary survey, GRBs of 113 with ABG showing pH of no acid-base derangement uh, and the ECG was normal sinus rhythm with heart rate of 76 per minute. Coming to secondary survey, patient was 55-year-old male with with non-hypertensive, had multiple episode of vomiting with headache and followed by an episode of seizure with lasting for about 2 to 3 minutes. And later he was in a postnatal confused state and was taken to nearby hospital. Following the seizure, he was feeling generalized tiredness and with loss of appetite and was found to have hyponatremia in the same hospital and was referred to AIMS for further management. Uh, there is no significant allergic history or environmental social histories. Coming to generalized examination, patient is moderately built and nourished with there is no pylorictus clubbing cyanosis lymphadenopathy. BP of 150 over 80 mm HG with pulse rate of 86. Saturation was maintained in room air with 98% and respiratory rate of 20 per minute. And in systemic examination, respiratory system air entry was bilaterally equal, normal vesicular blood sounds were here, and CNS patient was conscious but drowsy. GCS of E3, V2, M5 was noted. Pupil was equally reactive, and other system were within normal limits. Lab we run the lab parameters. On lab parameters, the sodium value was noted as 115 with potassium 2.4. The other values are within normal limits. We were diagnosed with electrolyte disorders, hyponatremia, and for the same we were gonna start with the sodium correction. Patient had a history of seizure.
This patient had seizure. What are
sir.
the differential diagnoses for this patient who had severe vomiting? After that, he developed seizures.
Hyponatremia itself can be a cause for.
It is the most important. See, now you know that it is hyponatremia. That's why you are telling. Without knowing, somebody is having altered behavior with vomiting and seizure. One is intracranial bleed. Most important thing, because that is the most dangerous. You cannot miss it. Then second one, anything?
Hypoglycemia.
Hypoglycemia. Second one. Okay, then.
Non-case of seizure disorder.
Non-case of seizure disorder. Okay, then. Vomiting induced.
Drug induced.
Vomiting. After vomiting, patient develops seizure, altered behavior, loss of consciousness.
Meningitis. Infections.
Encephalitis, not meningitis. Then. Vomiting can produce any vitamin imbalance, and it can affect the brain. Thiamine deficiency. That is one of the common presentation in pregnancy. Okay, for pregnancy lady can have severe vomiting, thiamine deficiency, Wernicke's encephalopathy. They can have all features of any other type of encephalopathy. And here in emergency room, one of the most important thing is hyponatremia. Okay, that's why you are telling hyponatremia is first. But there are other differential diagnoses. You cannot miss it.
We were diagnosed with electrolyte disorder, hyponatremia, and we were gonna start with sodium correction, sir.
Tell 3 investigations which will be done in hyponatremia. 3 investigations.
Hyponatremia, we should, other than serum sodium, we should look for serum osmolality, urine osmolality, and urine sodium, sir.
Okay. So 3 important investigations. That has to be done. Okay. Otherwise, your total investigation will be failure. So these 3 investigations must be done. Okay.
From the serum urine sodium value, we can correct.
First is serum osmolality. Why serum osmolality is done?
The sodium is the main component which gives the serum osmolality level of the body, other than the blood urea nitrogen and glucose. So we should check for the osmolality to know whether it's sued hypoosmolar or hyperosmolar type of.
What are the conditions you get hyperosmolar hyponatremia?
Hyperosmolar.
This patient had altered behavior. He had seizure. There is high chance for giving something else outside.
Hyperosmolar usually occurred used to hyperglycemia, mannitol.
Mannitol and dextrose, high volume dextrose and mannitol both can produce hyperosmolar hyponatremia. That's why we have to ask the history whether the patient has received any mannitol or dextrose. Like that we have to ask. Then hypoosmolar. Hypoosmolar is the real hyponatremia. Okay. Then urine sodium and urine osmolality. Why urine sodium is done?
In hypovolemic, usually sodium loss occur if it is becoming if the hyponatremia occur due to a renal cause. There is high chance for
so hyponatremia can be 3 important things. What are the 3 important things? Either patient is not taking sodium properly, or excess sodium is lost. So and dilution. Third one is dilution. So that we can divide into again it can be divided into hypervolemic, hypovolemic, and normovolemic. Okay. So if the patient is losing salt through the kidneys, then that can be picked up by urine sodium. Okay. Normally when hyponatremia is there, what will happen to the urine sodium?
Retained.
So there will not be any urinary sodium output. If it is increased, then it is a sign of urinary loss of sodium. If it is more than 40 milliequivalents, then it is a sign of possible SIADH. Okay. So your second investigation is urine sodium. What is the urine sodium in this patient?
Urine sodium was normal, sir.
Normal. So what may be the cause for hyponatremia? Urine sodium is normal, but patient is having hyponatremia. What may be the commonest cause in clinical practice in elderly individual?
Nutrition deficiency.
Okay. What it is called as?
Depletion
hyponatremia. Patient is not taking salt. Okay. Sometimes severe vomiting can produce loss of salt and water both. Okay. That is also possible. Whatever it is through the GIT, not through the kidneys. So patient is not getting salt properly, or he is losing salt through the vomitus. Okay. So sodium is low. Urine sodium does not show any increase in the urinary excretion. Okay. So what is the sodium here?
It was 115 lab value.
115. So what will be the total sodium deficit in this patient?
Total sodium
deficit.
Total sodium deficit is basically your normal sodium, serum sodium minus the patient's actual sodium into the total body weight, body water. That is into 0.6 in males and 0.5 in females.
Into body weight.
Body weight.
Okay. So that will give you the total sodium deficit. Okay. That doesn't mean that we have to correct sodium, that total sodium immediately. Now, how do you proceed?
Usually maximum correction we can give 10 to 12 milliequivalent, and usually we
in a day. So increase in the serum sodium should be maximum is 12 milliequivalents, but we don't correct that much also. 8 to 10, that is enough. Okay. If you correct more, sometimes it can produce dangerous effects that we'll discuss afterwards. Okay. So 12 milliequivalents.
So we correct maximum up to 8 to 10.
So 115 is now. Okay. You want to correct another 10, 125 it will become. Over 24 hours, your maximum correction is 10. Okay, so decide sodium minus actual sodium is 10 here. No need to calculate it. Into patient body weight into 0.6. That is what is the amount of that? What amount you got by calculating that? So that may be somewhere around 500. Most of the adult patient, if you are getting this much level, it will be somewhere around 500 to 450. Okay, so you take it as 500. Okay, so the 10 into 0.6 into body weight. Okay, so that suppose it is 500. How do you correct it now?
So we got the value of 500.
No. Here, should we correct fast or slow? That is a second question. Should we correct it very fast or slow?
Slow is enough, sir.
No, seizure patients.
Here we have a problem. Here patient is having seizure. So we have to correct fast. Okay. So two things you have to identify. What is a fluid deficit in this patient? You can use your ultrasound, IVC, collapsibility. You have to find out whether fluid deficit is there or not. But this patient is having severe hyponatremia that induced seizures. Okay. So how do you correct it? How do you correct it?
During
Basically, that 3% saline
Can be given as a bolus.
Bolus. So it contains 51 milliequivalents, 51.3.
Which one point?
530 is in 1000 ml. What we have is 100 ml. So 51.3 milliequivalents, one bottle. So that has to be given very fast because this patient is having seizure. We have to correct very fast. Okay. Suppose there is no seizure. How do you correct?
you can correct the sodium or slowly or 48 to 72 hours, sir.
Okay. Why are you correcting very slowly?
That again depends whether the hyponatremia is mild, moderate, or severe.
Okay. Two things are there. One is mild, moderate, severe. Second thing is rapid or slow. Okay. Slow, we have to be very careful. And mild hyponatremia also, we have to be very careful. Okay. So how do you correct?
Really, if it is mild, and then there is we don't really, and the patient is not symptomatic, just because the patient's sodium is low, we do not really start the correction. So only the patient has symptomatic features of
so symptoms can be divided into no symptoms, mild symptoms like weakness, third one severe symptom like altered behavior or seizures. So this patient is having seizures, so it is a severe symptoms we can take. Okay, so we have to correct it fast. Okay, we give bolus, then
after that we repeat the sodium. Serum sodium has to be monitored every 6th hourly. So then the next reading comes and then we look at the deficit now. And then with the deficit, we start ml per hour IV infusions. Depending upon the sodium deficit, we start the infusion. And every 6th hourly we monitor. If 8 to 10 milliequivalents have already been corrected, we stop the sodium, but we continue monitoring the serum sodium.
Okay, normally we correct around 10 to 15 ml per hour. Okay, that's all. We don't correct more faster than that. Only if the symptoms like weakness, altered behavior. But if there is a seizure, we have to correct it fast. Okay, but even then, in a day, we have to correct maximum 10 to 12 milliequivalents. If you correct fast, what will happen?
Cerebral pontine myelinosis can occur. Central pontine myelinosis. Demyelination syndrome.
It is called as demyelination syndrome. What are the two demyelination syndromes? Central pontine and extra pontine. Okay. Pontine myelinolysis is, what is the clinical finding? Extra pontine, what is the clinical finding? Pontine myelinolysis. Pons is having problem. So it will produce only brainstem problem. Okay, patient will be conscious. Whereas in extra pontine, other part of the brain is involved. Patient will have altered behavior, seizure, encephalopathy features can be there. Okay, so it is very dangerous to correct faster. Okay, especially in a chronic hyponatremia. Okay, if it is an acute hyponatremia, you can correct it acutely. If it is a chronic hyponatremia, correct very slowly only. Okay, if the urine sodium is very high, how do you correct? Urine sodium is 60 milliequivalents. How do you correct?
It is basically SIADH, sir.
It cannot be basically SIADH. There is a possibility of SIADH, like urinary tract infection also, or some other kidney disorder also. You can get increased renal loss. Okay, that SIADH is a diagnosis of exclusion. You exclude renal diseases. You exclude renal failure, cardiac failure, hypothyroidism. You exclude all these things, then you can diagnose SIADH. In SIADH,
fluid restriction and baptins we start.
Okay, so you give fluid restriction 1 liter, then you give Lasix, remove some amount of fluid, then you give 3% saline, then you give baptins. Okay, What are the vaptans you know?
Tolvaptan.
Tolvaptan and conivaptan. Tolvaptan is tablet. Conivaptan is injections. Okay, now continue. Sir, anything else? Anything else?
So intubation regarding this bad precaution hyponatremia patient. Is there any contraindication or agents chooser or any complication do you anticipate?
So this patient is having altered behavior, seizure. So sometimes you need to intubate this patient. So what do you do? How do you proceed?
So, sir, in this patient, we're only going to be intubating this patient in order to prevent aspiration. So, in that case, but the lungs, there is no lung pathology as such. So, we can go ahead with intubation, but only if the patient is going into status epilepticus, because once the cause has been treated, the patient will regain sensorium and patient can be extubated. So, in this case, we will go ahead with same as usual how we do in RSI with pre-oxygenation.
72-year-old.
72.
What other? See, the chest is clear.
So this patient will have to.
Other comorbidities.
And difficult intubation has to be suspected in the patient. One, because of elderly age. Probably he'll be edentulous or jaw cervical restriction. All of that will be there. So difficult intubation set has to be ready while we are attempting an RSI to begin with. Then for pre-oxygenation, patient can be put on NRBM or through bag and mask ventilation for about 3 minutes. Pre-oxygenation can be given. And for pre-medication, because of seizures, excessive secretions can be there in the patient or a tongue bite. Patient can have blood in the mouth, so suction has to be ready. And
Already also you might have aspirated. So that also rule out.
So as an agent, glycopyrrolate can be used, and in order to reduce the pain, opioid like fentanyl can be used as a pre-medication. For induction agent and anti-seizure
Release in analgesic.
analgesics. Then anti-seizure like propofol can be used provided the patient does not have severe hypotension. Then propofol would be an ideal choice because it has some CNS seizure anti-seizure activity. So
Again, if it is a hypovolemic hyponatremia. So use of propofol. Before selecting propofol, please check whether it is hypovolemic hyponatremia or euvolemic or hypervolemic. In a patient with hypovolemic, propofol may produce profound hypotension. Okay, we have to take care of it. So other choice may be etomidate. So the hypovolemia plus hypotension plus hyponatremia, the other agent is ketamine. Okay.
What happened to the patient after that? How much 3% saline was given for this patient?
For a day, we correct by 8 sir.
8 milligrams.
So by the third day, patient has improved a lot and patient is stable right
So
now.
if somebody is having severe vomiting and hyponatremia, he will have fluid deficiency also. 3% saline will not correct the intravascular fluid deficiency. Okay. So you have to give normal saline also. Okay. So that has to be done. You have to do the IVC, you have to see the urinary output, you have to see the BP. All these things you have to check and give fluids also along with your 3% saline. Okay. Where else tolvaptan can be used? Cardiac failure. Okay. So it's a newer treatment. It has not come in the guidelines, but tolvaptan can be tried in cardiac failure. Okay. Now what happened to the patient ultimately?
Patient is stable right now, sir. Seizure has not occurred after the first incident. And
Okay.
Patient sodium has improved.
Okay. So what is the final message? How do you manage a patient who is having vomiting with hyponatremia? That is very important. It's a hypovolemic hyponatremia. It's a hypovolemic hyponatremia. So what are the two things you will correct here?
One thing is dehydration.
Dehydration and
The second is the sodium level.
sodium. Both can be corrected. So can we give dextrose for correcting the dehydration? No.
You can again
What
worsen
happens? It goes to the extravascular compartment, not to the intravascular. So normal saline with 3% saline can be given. To correct the intravascular volume, you have to give normal saline or ringer lactate. To correct the sodium, you can give 3% saline. Okay, if there is urinary sodium loss, then you can give tolvaptan. Otherwise, there is no point in adding 12-aptan because it will not improve it drastically. Okay, it will not give any benefit sometimes. Okay. Anything else?
So basically, we have to decide whether to. We had to decide whether to give supplements of sodium or to like manage it as an SADH or a cerebral salt wasting syndrome. So once we're deciding on adding sodium
What is the
correction,
basic difference between SIADH and cerebral salt wasting syndrome?
this thing
It's a volume
volume
loss.
loss.
SIADH is a volume. It is a volume accumulating effect. Okay, it has got a intracellular volume accumulation. But we are not seeing the peripheral edema. Whereas in cerebral salt wasting, patient loses water and salt. Okay.
So clearly, we'll make a plan whether to correct how much amount per day. So ideally, like 6 to 8 or maybe like 8 to 10 milliequivalents per day we correct. So with that formula will be like the adequate correction that is expected by the current value into 0.6 into the body weight. The amount is the deficit. So deficit we divided by
That gives only total
deficit which we
only
need to
not
correct.
the 24-hour deficit. It's a total deficit that we have to correct
We have to
over
correct.
many days.
And then again, with that, we divide it by 51.3. Basically, if you take a 1 liter of 3% saline, it will contain 513 milliequivalents. So our bottle will be 100 ml bottle, so it will come containing 51.3. So which we divide by this total deficit we get, we will be getting the amount which we need to correct over time. And this again can divide by ml, 100 ml we can divide. So we'll get how much like ml should be total requirement for a period of 24 hours. Then again we divide it by the number of bottles. That is, every bottle will be containing 100 ml, 51.3 milliequivalents. Which if we are dividing, we will get ml per hour like value. This is the rate at which we have to correct sodium over a period of like every hour we have to give this much amount of 3% saline. Then every 6 hours we again recheck the sodium value and again reassess our deficit. And depending on the patient's sensorium improvement and other clinical parameters, we can again titrate our dosage whether to like go that fast or we can slow down the correction. Once the patient's sensorium or the presenting complaints have somewhat improved, then we can stop our correction and like observe the patient whether he will be improving without correction also. So that will be our basic plan of management. So this patient had 3 issues. One is dehydration, hyponatremia, and seizure. So if he's presenting with an ongoing seizure, first we'll be able to give some drugs like benzodiazepine to stop the seizure.
Always stop the seizure with your traditional drugs, not the 3% saline. Okay.
But again, persistent seizures, then we have to give a bolus of like 1 or 2 ampules. We can give like 100 ml can be given bolus. Maximum recommended is 3 we can give. Then we have to start aggressive correction as per the current protocols.
Okay.
See, at this age, which benzodiazepine you will prefer?
Short acting like midazolam can be given.
No, why not other things?
Lorazepam actually it'd be good for controlling the seizure, but there's a chance that he will go into like a airway failure.
It's a prolonged period, unpredictably prolonged period. Maybe coexisting renal problem may be there, liver dysfunction may be there, and as such, diazepam and lorazepam has prolonged actions.
So this condition you have very low GCS. Normally what we learn is if GCS is less than 8, intubate the patient. There are some conditions we should not intubate. One condition is this. Okay, if you unnecessarily intubate, they will be on ventilator. If you correct the problem, you will improve very fast. Tell some other condition where the GCS is low and you try to avoid intubation.
Hyperglycemia.
Hypoglycemia is most important. Hepatic encephalopathy. Because all these things, if you treat, immediately patient will revert back. No need to intubate, like thiamine deficiency. They're all give the initial treatment itself, patient will improve. Okay. Whereas some conditions like stroke and all, low GCS, you have to intubate because patient is not going to improve even with initial treatment. So GCS low is an indication for intubation, but not in all patients. Okay. Thank you.